Okay, so my talk is on steroid and ARDS and the cons. A little about overview. Touch base a little on the pathophysiology because ARDS is all about inflammation. Quick overview on stages. Lip score, also known as a lung injury score. Problems with using steroids. A little depth into ARDS Network, Meduri 2007, and the meta-analysis that Meduri conducted in 2008. And the summary. So this is what normal lung alveoli look like. So normal lung function requires dry patent alveoli, that they are closely situated to properly perfused capillaries, and the capillary endothelium itself is selectively permeable. Fluid crosses the membranes under control of two forces, hydrostatic and oncotic, while the serum proteins remain intravascular. Now in ARDS, this is what starts happening because of alveolar injury. Diffuse alveolar damage starts happening. There's release of pro-inflammatory cytokines like tumor necrosis factor, interleukin 1, 6, and 8. And these cytokines, they start recruiting neutrophils to the lungs, which once activated, they start releasing toxin mediators like reactive oxygen species, proteases, which in turn damage capillary endothelium and alveolar epithelium. So lung starts looking like this. Once the capillary endothelium is damaged, starts allowing protein to escape from vascular space. With this increase in interstitial fluid and damage to the alveolar epithelium, their spaces start getting filled with a lot of stuff. Blood, proteinaceous edema, and debris from the cells which are degenerating. Finally, surfactant is lost, resulting in alveolar collapse. So this is the same graph representation of how the ARDS happens. First 7 days is more the exudative phase, which is characterized by edema, hyaline membrane formation. 7 to 10 days later, your fibro proliferative stage starts, and that's the one which is marked by interstitial inflammation and disordered healing. Little about the lung injury score, also known as lung injury prediction score. It actually identifies patients who are unlikely to develop ARDS. Way back they did a cohort study of about 5,500 patients, in which 7% of them developed ARDS. Only 7% developed ARDS. So it actually resulted in a negative predictive value of 97%. So who had a lip score less than 4 did not develop ARDS. So that's the catch here. Now that had a higher negative predictive value. Those who had lips greater than 4, they had a sensitivity and specificity of about 69 and 78% respectively. Now how you give the scores out is this way. First I've outlined the medical reasons. Shock, give 2 points, aspiration 2 points, sepsis 1, pneumonia 1.5, and so on and so forth. The ones at the bottom are more with your surgery, orthopedic spine surgery, acute abdominal surgery, etc. So that's how you give out a lung injury score. Pathophysiology. So there's both systemic and pulmonary inflammation in ARDS, and the first week of mechanical ventilation determines whether it's going to be resolving ARDS or unresolving ARDS, and the eventual outcome of the disease. Now patients failing to improve their lung injury score by day 7, that's known as unresolving ARDS. They have persistent elevation in both plasma and BL levels of inflammatory cytokines, chemokines, markers of fibrogenesis, and overall higher mortality. Now research has shown us that insufficient glucocorticoid receptor-mediated inhibition of nuclear factor Kb, it's a central mechanism of dysregulated inflammation in ARDS. That's potentially reversed by glucocorticoid administration. Now again, most patients who succumb to ARDS, they don't die of respiratory failure, but actually complications, nosocomial infections, multi-organ dysfunction syndrome. Again, persistent inflammation contributes to this, and so naturally you think that anti-inflammatory medications would help improve the outcome of the ARDS. Problems are increased risk of neuromuscular complications like myopathy and neuropathy with steroids. ICU-acquired paresis, at least way back then when glucocorticoids were used with neuromuscular blocking agents, increases risk of secondary infection, especially when you do high-dose steroids and in early ARDS. Other things, hyperglycemia, poor wound healing, pancreatitis, higher chance of re-intubation, especially when you do a rapid taper, and increase in risk of death. So how it all started is Meduri, way back in '98. We did this early Meduri trial. Again, my colleague spoke about this. 24 patients received prolonged methylprednisolone, 2 milligram per kg per day. It led to rapid, progressive, and sustained reductions in the inflammatory cytokines, parallel improvement in lung injury score and MODS. Now, treatment was associated with significant reduction in mechanical ventilation and ICU mortality. Now, despite its limitations, it did provide proof that solimidrol treatment in ARDS is justified. So that's set off the ARDS clinical network, which is conducted over 6 years. During around this time, 3 additional trials were conducted. Now, they investigated prolonged steroid treatment in early acute lung injury. Way back then, it was known as acute lung injury, or ARDS. So a little bit about the ARDS Network trial. Again, we know this is a multi-center randomized controlled trial to determine efficacy and safety of glucocorticoid therapy. The hypothesis was that administration of moderate dose solimidrol to patients with persistent ARDS would improve clinical outcomes without much complications. Study conducted August 97 through 2003 November, 25 hospitals. Now, patients who were already intubated and on a mechanical ventilation, they were eligible for enrollment 7 to 28 days after their intubation and onset of ARDS. And the day of study entry, the PF ratio had to be less than 200. Methods was, randomly assigned 180 patients with ARDS of at least 7 days to either receive solimidrol or placebo in a double-blind fashion. 91 were given to placebo and 89 to the methylprednisolone group. The primary endpoint was mortality at 60 days. The secondary endpoints were number of ventilator-free days, organ-free, failure-free days, markers of inflammation, and infectious complications. So the study protocol, it was either IV methylprednisolone or placebo. So start off with a single dose of 2 milligram per kg of predicted body weight, followed by half milligram per kg Q6 hour for 14 days, and half milligram per kg Q12 hour for 7 days. It's tapered over 2 or 4 days, depending on. They went 4 days if the patient remained intubated after day 21. They did taper over 2 days if patients were extubated before day 21, developed septic shock or disseminated fungal infection. Again, data on demographics, all these were done with physiological characteristics, radiographic features. All these were recorded at day of study entry and on days 1, 2, 3, 4, 5, 7, 14, 21, 28. So patients were followed until they died. They were discharged home without breathing. When they were breathing without resistance, these were known as survivors. Day 180 or whichever came first. So this graph, this table actually looks at what happened at 60 days. Okay, so if you look at the 60-day mortality, it's almost ideal between placebo and solimidrol. Now, number of serious adverse events with neuromyopathy much higher with methylprednisolone, actually 0 to 9, and it was statistically significant. Now, this is more important. 60-day mortality from time of ARDS onset. Even steroids were started after 14 days. The solimidrol was started after 14 days. You see a significant increase in mortality in the methylprednisolone group. And a little more about the procollagen peptide 3. When presence in BAL was higher than the median, it was protective, but when it was lower, the actual mortality with methylprednisolone was higher. This is on 180-day mortality. The study will continue to 180 days. You see So the difference between placebo and methylprednisolone at 180 days remain the same. Neuropathy overall slightly higher with methylprednisolone, and when you started steroids after day 14, again it's much higher with methylprednisolone. Same thing with collagen peptide 3 when it was less than the median, the mortality was high with methylprednisolone. Even when you adjusted a 60-day mortality, when methylprednisolone was given after day 14, you do see a significant higher mortality with methylprednisolone. So a number of them who returned to assisted breathing, you see a higher number with methylprednisolone again. They died following return to assisted breathing. It's again higher with methylprednisolone. Again, higher incidence of neuropathy and serious events associated with neuropathy. So this graph my colleague already showed out. Probably mentioned the benefits of early intubation, but if you do see at day 180, like way out in the graph. I'll go to the next slide and come back. So at 180 days, in the placebo group, 29 patients had died, 58 were discharged home, and 4 had not been discharged home. They were identical in the methylprednisolone group as well, 28, 57, and 4 as a number. Come back to this. So way out at day 180, the difference was not much different. So the problems with methylprednisolone, mortality. So at day 60, mortality is not significant. At day 180, it was not significant. But when you gave methylprednisolone after day 14 of ARDS initiation, which is known as persistent ARDS, they actually increased mortality. Ventilator assistance was resumed, more in the methylprednisolone group, 6 versus 20, 20 versus 6. Neuropathy, again, much higher in methylprednisolone versus placebo. This included weakness of arms and legs and sensory deficits. So, again, the larger benefit observed during steroid treatment of unresolving ARDS was lost with rapid tapering after 48 hours. Again, in this trial, methylprednisolone was removed within 3 to 4 days of extubation. That likely contributed to deterioration in the PF ratio, high rate of reintubation, and associated mortality. They say the reason is, likely reason is both the systemic and pulmonary inflammation continued for weeks. In ARDS, they extend well beyond the extubation period. The half-life of methylprednisolone is only about 4 to 7 hours, and you see greatly diminished effects 24 to 36 hours after discontinuation. And exposure to glucocorticoid therapy leads to a significant reduction in the receptor number and binding capacity, and rapid tapering can actually lead to rebound inflammation, fibroproliferation, and exaggerated cytokine response to infection. So, in this clinical trial with persistent ARDS, there was no benefit of steroids on survival in the hospital, especially at day 180. We initiated methylprednisolone 14 days after onset of ARDS. It actually increased mortality both at day 60 and day 180, and you actually increase the rate to return to assisted breathing. Possible explanations are complications of glucocorticoid therapy, such as neuropathy, withdrawal of glucocorticoid, including shock after patients with breathing without assistance, some pulmonary parenchymal causes such as recrudescence of fibroproliferation, and patients who survive at least 14 days of ARDS, they have less active fibroproliferation reflected by lower levels of collagen peptide 3 and PAL, and these are less responsive to corticosteroids. So next is the Meduri late trial that was published in CHEST 2007. So their objective was to determine low dose methylprednisolone infusion in early severe ARDS. It was a randomized double-blinded study. Happened in 5 ICUs, 5 hospital ICUs in Memphis between 1997 to 2002. They recruited 91 patients. Again, severe early ARDS, which is defined as less than or equal to 72 hours. 63 were recruited to methylprednisolone and 28 to placebo. Again, 2:1 randomization. The primary endpoint was 1-point reduction in lung injury score or successful extubation by day 7. Now, this trial, one of the reasons I did this is way back in '87, Bernard did a trial with high-dose methylprednisolone over 1 day. So this was way different from that, because the protocol they followed was they gave either methylprednisolone or placebo. Slower loading dose was much lesser, 1 milligram per kg. So the infusion of that was day 1 to day 14, followed by half milligram per kg per day from day 15 to 21, then quarter milligram per kg, then 0.25 from 26 to 28. Now they were extubated between first 2 weeks. The protocol was directly advanced to day 15 of tech therapy and tapered out. Again, the study was analyzed as intention to treat. Primary outcome was improvement in lung injury score by day 7 or extubation. Those who remain intubated on day 7, improvement in lung function is defined as reduction in lung injury score more than 1 point, or if study entry lung injury score was less than 2.9, day 7 lung injury score less than 2. Now the third analysis, there was significant difference in lung injury score improvement on day 7. It was about 70% versus 35%. Now you do see a big branching by day 7 that there's improvement in C-reactive protein. Improvement in lung injury score with methylprednisolone and decreased CRP. Same thing with continuation of mechanical ventilation and survival. So methylprednisolone actually seemed beneficial here. The problem was mortality by day 7 for patients with catecholamine dependent shock was similar, 80 to 77%. Those with relative adrenal insufficiency had a lower response to methylprednisolone, and among control subjects, adrenal insufficiency affected the proportion of improvement as well. Among the 70 patients who received methylprednisolone, most of the patients who got methylprednisolone, they developed neuromuscular weakness and delayed healing. Now this is lower than ARDS net, likely related to the lower dose that was used in late Meduri and limited use of neuromuscular blocking agents. The late Meduri again is the first trial that investigated efficacy and safety of low dose, prolonged steroid administration in early ARDS. Again, it tested a model that placed dysregulated systemic inflammation at the core of ARDS. Surrogate markers were for pulmonary inflammation, it was the lung injury score. For systemic inflammation, it was CRP and multi-organ dysfunction syndrome. Now, the findings supported an original hypothesis that Meduri brought out, that downregulation of systemic inflammation with early introduction of prolonged steroids hastens the resolution of pulmonary organ dysfunction in ARDS. Limitations, however, were a small sample size, imbalances among patients with catecholamine dependent shock that may have biased the estimate of the treatment effect on mortality. So you need a larger trial to support this finding. Additional limitations were previously reported limitations in chest X-ray scoring in patients, failure to incorporate a weaning procedure, and failure to strictly monitor implementation of a event protocol. So Meduri, what he did was he did a meta-analysis of 5 studies later It was published in Intensive Care Medicine in 2008. So this compared design and results of randomized trials that patients received prolonged steroids, that is more than 7 days, either with ALI or ARDS. He selected 5 trials. The total number of patients recruited was 518. And these patients consistently reported improvement in gas exchange, decreased markers of inflammation, and decreased duration of ventilation and ICU stay. Now, 2 early small trials showed marked reduction in relative risk of death with steroids, but 3 later larger trials, although they were nominally beneficial, did not show the marked reductions seen in the earlier trials. But what they did show is, if steroids were introduced before day 14, it actually caused a reduction in relative reduction in death. So these were 5 trials that he looked at. So the ones in boxes are the later trials. The 4th one out there, Meduri 98, is the early Meduri, which set off this barrage of studies. But the ones without the boxes, you can see the number of patients recruited are small, whereas these were the larger trials with 177 patients, 91 and 180. The last one, of course, is your famous ARDS Network trial. Again, on the 5 randomized trials, if you see the earlier ones, Meduri 98, the one in 2005, shows a much more favoring treatment. But the latest studies, you see the relative risk. The favored treatment is only marginal. Same thing if you remove patients randomized after day 14. Earlier studies showed much favor towards treatment, and the later ones are only marginal. And these 3 trials, when you gave prolonged steroids for a week, after removing patients randomized after day 14, again, the benefit is only marginal. So these were the 2 undissolving trials, early Meduri versus ARDS. More of the same. Early Meduri went more by lung injury score. ARDS Network was more by PF ratio less than 200. Pretty much showing the same. ARDS Network was more focused on glucocorticoid treatment, timing of initiation, dosage, and duration of treatment. So summary is, it all depends on when steroids are initiated. When you initiate late, that is during persistent ARDS in the fibroproliferative phase, as the ARDS Network trial did, especially after day 14, methylprednisolone actually increased the 60-day and 180-day mortality. It did increase ventilator-free days, shock-free days, and all that, but also increased neuromuscular weakness. When they were increased early, as in the Meduri of 2007, also known as late Meduri, it reduced mechanical ventilation, length of ICU stay, mortality, but the results were not propagative or definitive given the small size and imbalances in treatment arms. It's kind of my thought. Questions?
phenotype studies that have been done with the ARDS Network patients, they did not describe that there was anything that was clearly assigned to phenotype 1 versus phenotype 2. Certainly, I think that's something that people are trying to look at to see if there's an easy way to say who's which phenotype. I think for steroids, the question is timing enough of a surrogate? You 7 to 14 days is a surrogate for a group of patients who are likely to be inflammatory. And that, I think, is the point of the question. I mean, I think it's clear later that there's no benefit. Whether there's benefit early is the question. Whether it's going to be earlier than 7 days, yeah, that's a discussion. But we don't know yet. I don't remember if it's in the last studies, they did VALs and everybody, whether they could go back and do phenotyping. They obviously have the protocol of Meduri, because they divided up the, I don't know if anyone's tried to use these phenotyping data to just ask the question, who's actually, who's going to respond to this. One of the thought processes in the connection was that if you rebound after you stop the steroid, you can be still inflammatory.
Yeah.
Do you see that evaluated with the steroid?
After, it goes after.
No, I don't get it. Okay, so between 7 and 14 days. Okay, I think it's a different question.
No, but I mean, you're asking about
So none of us use ECMO. I mean, the majority of our ARDS patients don't get ECMO. True? Agreed, and I'm not arguing that we shouldn't use ECMO. I think it's a different question. Given that, and we typically don't use ECMO at ARDS. Like, if we're going to use it, we would use it early. Maybe. Again, it doesn't matter. I'm not looking, I'm just curious. I am certainly one who looks at steroid trials and other studies, or even other steroid trials. I'm sure it's not going to hold up when you study it in a bigger group. But this, I think, is unique in that the biggest group we studied, and at least if you're looking at 3 days, 5 days off of that sooner seems to me enough of a difference to argue the therapy. I don't know.
Mortality benefit. It
The
started
mortality
before.
benefit is,
Seen there.
I think the mortality difference doesn't include the patients who are treated late being more than 14 days. When you look at the mortality difference for patients who are treated within 7 and 13 days, it's not statistically significant, but it's a 10% difference. Right.
Not at the hypothesis scale or something.
Absolutely. No, and even 7 and 14 is hypothesis generating. So I guess those are both fine arguments of why not to do it. Because they didn't say they wanted to look only at 7 and 14 days, so you could make an argument that that's just hypothesis generating. And the fact that there isn't a mortality. That's what I'm asking. I think those are both good arguments.